Fine.
Yes.
Okay, perfect. All right, it's really a pleasure for me to be back. I had the privilege of working with HealthTree before for acute myeloid leukemia, and I'm pleased to be talking about a topic that's near and dear to my research interest, which is immunotherapy for acute lymphoblastic leukemia. And just to start by saying that, as the introductory video was suggesting, I really am here to help everyone feel informed. A lot of these topics may seem complex with complicated terminology and words, but I firmly believe that a lot of this should be understandable no matter your background. So if you have any questions, please feel free to chime in. All right. So I do want to start just by bringing us all onto the same page about what this condition we're going to discuss today is, B-cell acute lymphoblastic leukemia. This is generally a rare disease, as you can see here, based on statistics from the governmental SEER database, comprising just 0.3% of all new cancers diagnosed. You'll see, though, that with our treatments, nearly three-quarters of folks are able to live for 5 years or more, which is good to see. But I think we have to always, and I tell my folks that I care for, that we have to take these numbers, these summary statistics, as we call them, always with a grain of salt, or many grains of salt, as you can see here. And that's because not every individual with acute lymphoblastic leukemia is the same. And shown here are the folks that are diagnosed with this condition. You can see that about half of them are pediatric in nature. These are individuals that are less than 20 years of age that receive treatments much different than folks that I care for in my adult clinic, and for whom, for these younger folks, results are typically very excellent, and acute lymphoblastic leukemia is very curable. The task is a bit more challenging for our older individuals, which still make up 47% of the population, but with a very widespread, as you can see here. So that's, I think, the first realization about the condition we'll be talking about today. If you were to focus in on just the adult population, you might further come across images like this, which aims to show sort of the percent of people remaining alive 1, 2, 3, 4, 5 years after treatment in this study. But still, I think we have to acknowledge that, again, not every individual with acute lymphoblastic leukemia are identical. Again, more grains of salt. And that's because one of the major ways that we divide acute lymphoblastic leukemia is into the category of Philadelphia chromosome positive or Philadelphia chromosome negative B-ALL. And I'm happy to discuss more about what that precisely means if it's of interest to anyone, but you've likely heard of that designation before. And you'll see that the two groups of patients, unfortunately, don't do equally well, with one doing a bit better than the other. And of course, if you then sort of slice the pie differently by looking at B-ALL folks of different age groups, you can also see that folks who are older in age also have a more difficult time doing well with therapy. Still, more grains of salt. And why is that? Well, the images that I'm showing you and the images you might see when if you are to do a Google search and so forth, be careful where and when this data was obtained from. So these images I'm showing you come from 2005. And in general, it's actually pretty hard to find a nice, neat summary of any kind for ALL patients, just again, because of how different these different subtypes might be. And secondly, because of the topic of our discussion, immunotherapies. So immunotherapies are recent additions to our ability to treat B-ALL that have really been game changing. So a lot of these summary statistics, numbers, and figures really can be quite outdated and not relevant per se to how patients currently do with our current therapies. So I'd like to turn now to talking about immunotherapies for B-ALL. But just to start by asking, well, what does immunotherapy even mean? In oncology, immunotherapy, this term, is sort of thrown out quite frequently. And broadly speaking, it basically just involves therapies that involve your immune system. Um, but that can mean very many different things. It could refer to antibodies, cellular therapy you may hear about, immune checkpoint blockade, bispecifics, CAR Ts, antibody drug conjugates, so on and so forth. There's a lot of things that fall under this umbrella. So how do we sort of make sense of this, and which one of these are even relevant for the treatment of B-ALL? And I think probably the easiest way to organize this is to just divide it in terms of, well, first of all, what is your body receiving? Are you receiving antibodies or are you receiving immune cells? And then we'll start with antibodies here. So if we zoom in on antibodies, I think the next question to ask is, what are the antibodies sticking to? Are the antibodies just sticking to cancer cells? Are antibodies sticking to cancer cells with a chemotherapy drug attached, which we call antibody drug conjugates? Or is the antibody sticking to cancer cells and your body's own immune cells, which we call T cells? And these types of antibodies we call bispecific antibodies or T cell engaging antibodies. All right, and of course, antibodies are otherwise naturally produced by your body to fight infections, but can also be produced in the lab and sort of given as a drug, just to kind of bring us all on the same page. All right, so if we looked at antibodies and we focus on just the cancer cells, one example of how antibodies work is by targeting things that are expressed on the surface of your cancer cells. So on the surface of your cells, all in your body, including cancer, on the cell surface are proteins that perform various different functions. Here, as an example, is a protein called PD-1. And PD-1 is a protein that tells your immune cells, your body's own immune system, to not kill the cancer cell. It's a way for the cancer cell to evade your immune system. So one way antibodies might work in this case is that the antibody blocks this PD-1 protein and blocks its ability to tell your immune system to ignore it, therefore allowing your immune system to kill that cancer cell. Another common protein on cell surface that you may hear about, particularly for B-ALL, is CD20. And we have also antibodies that can block it, and it tells your immune system again to eat the cancer cell instead. If we look at cancer cells, if we look at antibodies that can stick to cancer cells and has a chemotherapy drug attached, this is one such example where if you have CD22 on your cancer cell, the antibody can attach to it, fine, but this time the antibody brings with it chemotherapy. It's almost like a homing missile, so to speak, for your chemotherapy, so that instead of giving chemotherapy throughout your body and all of your body is affected by the chemotherapy, both your healthy cells and your cancer cells, here the antibody brings the chemo specifically to cancer cells. That's at least the idea. It's not perfect, of course, there's still side effects, but it's a much more targeted type of therapy. And here, once the antibody arrives at the cancer cell, the chemotherapy then is able to kill the cancer cell in that fashion. All right, and then lastly, are antibodies that stick to both cancer cells and your body's own immune cells, and these are called T cells, as I mentioned. And these antibodies look a little bit different. They're not just binding with one end and then bringing a chemotherapy or not, but rather there's two ends to them. We call these bispecific antibodies, again, as I mentioned. And the magic here is that on the other end, it basically sort of pulls in your T cells and allows your T cells, your body's own immune cells, to do the dirty work for you, basically. Right? So there's no really chemotherapy involved. This is a harnessing, enhancing of your own immune system. All right, so again, in organizing immunotherapies for ALL, just even thinking about antibodies specifically, there are many different categories here that are pretty different to keep in mind when discussing this with your treating physician. What are some examples, right? We've done enough talking about pictures, but what are some actual drugs? So if your antibody binds to PD-1, PD-L1, CTLA-4, CD20, and so forth, then your drug could be pembrolizumab, nivolumab, and these are terms you may have heard, atezolizumab, durvalumab, et cetera, et cetera. Importantly, these top three also go by the sort of category term of immune checkpoint inhibitors. And furthermore, these are not usually used for acute lymphoblastic leukemia, which is why I think the term of immunotherapy can include much more than what is necessarily relevant for your own care. And I think that's just something I really wish to highlight and for you to be mindful of, especially if you might come across some of these drugs that just do not relate to the treatment of B-ALL. CD20, though, is a target of rituximab, and that is commonly used. Going to the category of antibody drug conjugates, the drug that we frequently use for ALL is inotuzumab, ozanimod, and then thirdly, the bispecific antibody that I mentioned is blinatumomab, which is increasingly making a presence in our ability to treat B-ALL. All right. I'm going to move on now to the category of immunotherapies in which you receive immune cells. Here, there's not as many categories, so to speak. The main question is, okay, you're receiving immune cells, but what kind of immune cells are you getting? Are you getting your own immune cells that have been modified and given back to you, which are called autologous CAR T cells? Or are you receiving someone else's immune cells that might be modified and then given to you? So from someone else to you, we call that allogeneic CAR T cells. I think the easy way to remember this is auto means sort of to yourself, from yourself. And if I were to depict this graphically, right, it's sort of the same idea. You have your cancer cell here. Instead of an antibody, like the other categories I showed, instead you're modifying the T cells to generate T cells that have something called the chimeric antigen receptor. This is a mouthful, but really all that means is that it's a special type of receptor that allows your CAR T, your T cells to identify cancer cells in your body. And by virtue of your T cells now having this CAR protein, we call them CAR T cells. All right. But they still come from you if they are autologous CAR T cells. They've just been modified. There are two important CAR T cells, autologous CAR T cells approved for B-ALL that you may have come across. These have really made significant progress in our ability to treat B-ALL. And the two are brexacabtagene autoleucel, and the second is obicabtagene autoleucel. It's a mouthful, so we abbreviated. We give it nicknames, Brexacel, Obicel, and their brand names are Tecartus and Alcatzal. Alcatzal is hard to say, so we just say Obicel. If you're part of a clinical trial, though, involving immune cells, you may be receiving sort of the other immune cell types that may be similarly modified. Moving on, if you're receiving immune cells from someone else, number one, there are no approved such therapies for B-ALL. So if you are receiving immune cells from someone else, it's almost certainly as a part of a clinical trial. In a clinical trial, by virtue of trying to improve our ability and our current standards of therapy, they likely will be using cell types that are less common. Yes, you can still get CAR T cells, someone else's T cells that get modified and they receive the CAR protein, CAR T cells, or they can take someone else's NK cells, these are natural killer cells, a different type of immune cell, modify them, give them the CAR protein, and then give the CAR NK cell to you. Or they might just collect NK cells without the modification from other people, give them to you, or even yet another type of T cells called gamma delta T cells that can go and be given to you as a therapy. All right. So beyond organizing and categorizing them, I'd like to now move on to talk about when you might see these therapies. And to do so, I return back to those two main categories of BALL that I alluded to before, Philadelphia chromosome positive and Philadelphia chromosome negative. We call them, again, we like nicknames, PH positive or PH negative. I want to start again just by reorienting us to the usual journey or pathway of this treatment direction. If you have PH positive BALL, generally the treatment in the beginning is with a tyrosine kinase inhibitor with steroids, with or without additional chemotherapy, depending on the specific regimen your doctor has chosen for you. After that, a lot of times people will receive blinatumomab. And then there's always the question, should any one individual in particular be headed to a bone marrow transplant? Recognizing that historically in the past, PH positive was considered a high risk subtype of ALL for which bone marrow transplants were felt to be the only chance at a potential cure. I put this in dotted lines because this is very much debated now in the era of new immunotherapy. So again, highlighting the fact that what we may have seen or heard from data from the past may not necessarily be entirely relevant now in the era of new immunotherapies. The treatment journey for PH negative BALL is a bit more complex and a bit more variable. There are a lot of regimens that could be chosen at the very beginning. They each have multiple steps with different names, so hard for me to label them neatly. But you get the idea. And after that, usually comes the incorporation of blinatumomab, again, with the ongoing debate of whether an individual needs to go to a transplant. I should highlight, though, that, again, in keeping with the theme that the entire field is evolving with new therapies as we speak, these treatment journeys might very well change in the near future. As one example, blinatumomab now is being considered to be incorporated earlier in therapy, perhaps in between these other boxes of chemotherapy. All right, so do talk with your physician to review any specific treatment schedule for your particular situation. Okay, but more specifically, if I were to pull in those pictures from before, again, when could you receive these therapies? If you're PH positive, frontline, meaning you just started treatment, yes, blinatumomab will come. It'll come after the initial phase of treatment, but the other agents don't really have a role at this time. If you're PH negative frontline, yes, there's blinatumomab still, but you can also have your doctor incorporate rituximab as a part of the treatment in the beginning, or even inotuzumab up front. Inotuzumab is, if you were to receive it early in your treatment, it would most likely be in a clinical trial because its approval at the moment is only in leukemia that's come back, relapse refractory leukemia. Nevertheless, I include it here in case that you are on a clinical trial with inotuzumab. But still, these CAR T cells with these long names do not really have a role at this time in the frontline setting. Now, if leukemia comes back, as I alluded to, what we call relapse, then a lot of these therapies are considered. Each of these three on the right, in particular, are approved therapies for relapsed leukemia. I put in dotted line, though, the fact that we just don't use them as much anymore. Rituximab, because it's mostly used in the front line setting, right, as you start treatment, as I showed you. And blinatumomab, as I also just showed you, is being incorporated frequently into therapies that you receive right at the beginning. So if your leukemia comes back after that, I think most doctors would be reluctant to necessarily try the same thing, the identical thing again. But these other therapies then have more of a role, inotuzumab, and in particular, the CAR T cells. So for the last section of this talk, and I think I'm moving through things pretty quickly, so I'm very happy to answer questions and also scroll back if anything is confusing. But for the last part of this, I'd like to focus on CAR T therapies specifically, because when you think about immunotherapies, at least that's often top of mind for a lot of doctors and things online. So CAR T therapies are not as easy to give as just a drug, right? It's hard to just show up for an appointment and get CAR T therapy. Instead, I remind us that these are your own immune cells that have been modified. So if you think about it, someone has to get them from you, someone has to kind of tinker with them, and then someone has to give them back to you, right? So there's already sort of a much more involved process. Again, these are your own T cells that get the CAR antigen. Just wanted to show that again. And again, there are two types, Brexucell, obe-cel. What the treatment journey looks like is as follows. Here you are about to get your own T cells collected for CAR T manufacturing. This is a process that we call apheresis. And it requires an appointment, and you'll have a large catheter put into you for the blood to kind of circulate out and for the T cells to be collected. The line then comes out, so don't worry. But then it takes 3 to 4 weeks for these T cells that are collected from you for them to turn into CAR T cells with that very special CAR protein on the surface. Then, of course, they are given back to you. The question, of course, is what are you doing in the meantime, right? You still have, sorry, and I use you figuratively, not in a pointed fashion. For folks waiting for CAR T therapy, they may still very well have acute leukemia that needs some sort of control. And we call that therapy that they receive during this waiting period, we call that bridging therapy. And it's a bridge because it's a bridge to a destination. It's not in and of itself the solution, right? We're not trying to cure the leukemia with bridging therapy. We're trying to buy time while your CAR T cells being made. Then you are likely brought into the hospital and you receive chemotherapy that we call lymphodepleting chemotherapy, or LD chemo, which you may hear about as well. And that's meant to sort of really push down your own immune system to make room, so to speak, for the immune cells that we're about to give you. So the immune cells go back into you, as I show, and then you'll likely be in the hospital. At least that's what we do at my center. We keep folks hospitalized for about 3 to 4 weeks. It is a long period of time, I'm sorry to say, during which, though, we perform the important task of monitoring you for toxicities, which is actually the next focus of this discussion. All right, but this is the entire patient journey for CAR T cells. It takes planning, and as you can see, sometimes it takes leukemia that stays relatively well behaved. And so as much as we hope to give anyone we could this therapy, unfortunately, there are individuals in whom the leukemia doesn't stay well behaved or moves too quickly for this therapy to be effective in time. Moving on to toxicities. This, I think, is very much worth some discussion because CAR T therapies, by sort of really improving our ability to treat ALL, has come at some cost, at least when we first started using this therapy. And the cost has been in the form of toxicities. 3 in particular: low blood counts, cytokine release syndrome, or CRS, and then even more of a mouthful, immune effector cell-associated neurotoxicity syndrome, or ICANS. So let me go through these one by one, just so you've heard about it. I don't think don't feel the pressure to memorize, but familiarity, I think, is important. Low blood counts are probably the most intuitive. With the receiving of lymphodepleting chemotherapy, LD chemo, and then the CAR T cells, your normal blood counts might drop. And this can last several weeks before recovering. during which you may be at risk for bleeding, bruising, fatigue, infections, and that's why you might receive antibiotics, blood transfusions, all these sorts of things that you're in the hospital for, right? You're there so that your healthcare providers can respond quickly to any of these complications. You're also there for CRS and ICANS monitoring. So CRS is cytokine release syndrome. It's characterized by fevers, possibly low blood pressure, and possibly difficulty breathing. The way to think about this, I think, is that you are receiving immune cells, your own immune cells, that are attacking your cancer cells. It's almost as if you're fighting off an infection, but instead of an infection, you're fighting off cancer cells. But the side effects are still sort of typical of what might come about with an infection. Fevers, if you get really bad infections, you develop sepsis, sometimes the blood pressure drops. This CRS phenomenon is analogous to that. And it's also, in a way, desirable, right? We often use CRS, some amount of CRS, as sort of reassurance that the CAR T cells are given back to you are in fact doing their job, attacking cancer cells and creating a little bit of fever. Of course, the trick is that we don't want you to have too much fever. We want sort of a balance, right? We also don't want to turn off all fevers because what if that means we're turning off the CAR T cells? So we want to find a balance, and we do so with drugs like tocilizumab or steroids. And you'll be under the expert care of sort of cell therapists, basically physicians who are experienced in the management of CRS. So you'll be under watchful eyes. All right, but CRS is something you'll hear a lot about. And lastly is ICANS. The simplest way to think about ICANS is that this is just neurotoxicity, despite that very long name. And neurotoxicity can come in many different forms. It can be as subtle as sort of mild confusion, just speaking a little bit improperly, to headaches, to worst case scenario, seizures, coma. These frequently occur during or after CRS, and treatment here is with steroids. CRS and ICANS in particular can be life-threatening. I don't want to sugarcoat that, and it often is the major risks that I review when I discuss CAR T therapies with with the folks I care for. But we are getting better, right? All these new CAR T therapies have been out for several years now. We're now much more aggressive in treating the first signs of CRS and ICANS. And it's not through sort of negligence or oversight, but through the natural learning of a new type of treatment. CAR T cells, there just hasn't been any other treatment like CAR T therapies until recently. And through all of our collective experience, CRS and ICANS management now is very feasible, and people are able to get through CRS and ICANS safely. Nevertheless, still toxicity worth keeping in mind when making a decision about proceeding with CAR T therapies or not. For CRS and ICANS, a little bit more detail I want to slip in here. CRS, we talk about it, and you may hear us talk about it in the hospital in terms of grades 1, 2, 3, 4. And the grades speak to the severity of CRS. All CRS needs at least a fever, as you can see. If you develop low blood pressure, that becomes grade 2. If you develop really low blood pressure, that's grade 3, and so on and so forth. If your oxygen levels are low, you're a grade 2. If they're really low, grade 3, so on and so forth. What I hope for you to take away from this is that grade 1 then is just fever. And you and I and everyone are entitled to have a fever from all sorts of reasons, not just from CAR T therapy. So don't be too alarmed if you're sort of described as having grade 1 CRS. That's just a fever. Could you have an infection? Could you have, all sorts of other potential causes unrelated? Perhaps. Still, for our own sort of documentation and monitoring, we will label this as grade 1 CRS. Grade 3 and 4 are usually what catches a lot of people's attention, but as I mentioned, and historically is what prompts a lot of treatment for CRS. But like I was describing, we're now much more aggressive, such that even grade 2 now, we will jump to intervene. In grade 1, we're keeping a very watchful eye on. And then lastly, I have a bit more detail about ICANS. What you may hear in terms of ICANS is this ICE score, ICE score. And this is a set of 10 questions, each given 1 point, asking sort of common things, month, year, hospital, city, name 3 objects. Can you follow a command? Can you write a sentence, count backwards by 10? But they're simple enough for us to capture subtle changes that might suggest neurotoxicity. All right. And based on the score one gets, we're able to then sort of give it a grade 1, 2, 3, and 4. In addition to that, sometimes, like I mentioned, the neurotoxicity can be quite severe to the point of seizures and other neurological findings. But really, we monitor closely with ICE scores and we intervene quite proactively. So it's uncommon to see these high grade events. All right, show me the numbers, right? For those for whom numbers might be helpful, here's a table that I endeavored to summarize these risks for. So on the left here are the immunotherapies that are most relevant for ALL, blinatumomab, Brexucab, obe-cel. There's yet another CAR T cell I didn't spend too much time on, and that's because primarily it's used for folks less than or equal to 25 years of age, Tisa-cel. For the most part, we will be using Brexa or obe-cel for our folks. And then on the right here, I have the rates of CRS and ICANS broken down by any grade. So that's 1, 2, 3, 4, or just grades 3 or higher. So remember, for CRS, fever, just run-of-the-mill fever gets you grade 1 already and would be counted as any grade. So in a way, one way to think about it is just looking at the grade 3 or higher number. The takeaways here are, number one, blinatumomab in general, in the way that we give it now, doesn't tend to cause a lot of CRS, but ICANS is something that we watch for, confusion and so forth. And this is why if you're starting blinatumomab for the very first time, at most centers, you'll be doing so inside the hospital. The risk is very different, as you can deduce from my earlier discussions, for Brexucab and obe-cel. These are potent therapies with equally potent side effects. So grade 3 or higher CRS, ICANS, much higher rates, right? Nearly 25%. If you look at any grade, it's 60 to 90%, right? So almost everyone feels some sort of side effect from this CAR T therapy. And also to a point I made earlier, it's because of the risk of this CAR T therapy. In addition to that waiting period for the CAR T cells to be made, that ends up preventing some patients from successfully receiving this treatment, right? If the toxicity in particular is too high, then we might be more nervous for those who are perhaps older in age or with other medical conditions from getting a CAR T therapy. I highlight that because the most recent approval in our field is obe-cel, and its main innovation is in reducing toxicity to make CAR T therapy able to be more safely given to more people. So here I have broken down, BM stands for bone marrow. So there are 3 levels here describing the amount of blasts in your bone marrow. If you have over 75%, which is a high burden, 5 to 75, medium, or less than 5%, low. And you can see that for those with very little blasts in the bone marrow, the toxicity rates are much lower. I mean, 0% for grade 3 or higher CRS or ICANS, right? But even if you were to have more leukemia, this grade 3 or higher rates remain low, even all the way up to disease burdens exceeding 75%, right? 2% still of grade 3 or higher CRS compared to the 20-some% previously with Brexucab. Now, I should caution that comparing Brexucab and obe-cel in this fashion is flawed. These two were not studied in a way that sort of compared them head to head in the same study. So there's a lot of potential variables that are not accounted for by comparing numbers across different studies like this, what we call cross-trial comparisons. That's generally a big no-no for us to do as a clinician and academic physician. But we have to make available the data available to us, or we have to make use of the data available to us, and that would seem to suggest that obe-cel has a lower toxicity profile than Brexucel. Does that come at the expense of how well the drug works when you compare the two? That no one can say. Um, Certainly not in the data available. Um, but at least safety-wise, I think a lot of us are thinking about obe-cel if safety for any specific patient is a concern of ours. All right. Finally, this is my last slide. How long do these things last, right? They might sound terrifying. When do they occur? How long do they last? For Brex and obe-cel, again, I summarize. Again, please take with many grains of salt comparing numbers across different studies. But usually for CRS, about a week duration, a week of, a week into CAR T therapy is when it occurs, and it lasts about also a week. For ICANS, a little bit later, median onset 9 days, 12 days, but also lasting about a week. You will see, though, that the range is very wide, right? And it's unfortunate because the way these numbers were presented in one study for Brexucel and in another study for obe-cel, one gives you the range and one gives you the IQR, which is the interquartile range. And just to kind of flash us all back to high school math, the range really takes the maximum minus minimum, whereas the interquartile is just between the 75th percentile and the 25th percentile. All right, so you really can't compare across, but it does demonstrate that you will be watched, right? It's hard to predict with certainty. All right, I think with that, I'd like to thank HealthTree, absolutely, everyone here in attendance. I'm here at your service. Please ask any questions if I can be of help.
Thank you
This is
so
Lori.
much. Go ahead.
Can I ask a question?
Yeah, of
Yeah.
course.
My 31-year-old daughter has ALL. She is currently on Blincyto for 28 days, but she has, and we hardly ever see this, she doesn't have the Philadelphia mutation, I think, if I'm saying that right. She has a
Mm-hmm.
TP53
Mm-hmm.
mutation, and they're telling her, I mean, her last three bone marrow biopsies have come back with zero cancer cells. She started with 52,000 blasts, so we're blessed. But the TP53, they're saying this is her best chance. And then she'll do a stem cell transplant after this of it
Mm-hmm.
not relapsing. Is TP53 kind of unusual or?
Yeah, no, thanks for sharing, and I'm very sorry to hear that
That's okay. Thank
for
you.
her. Although I'm very reassured and pleased to hear of the good response. I think
Yeah.
the situation you highlight is precisely why I had this dotted line around a bone marrow transplant. To answer your question, P53 in ALL generally comes alongside a lot of other genetic changes of the chromosomes. So I wonder if she has what we call a complex chromosome, or there's some other sort of more technical terms. Chromosomes are those X's and well the X's that you see from high school biology and so forth, where large
Yeah.
chunks of DNA are missing or misplaced. So it generally, together with P53 mutations, generally suggests that this ALL type is
Yeah.
higher risk. And historically, for these higher risk types of ALL, we would consider a bone marrow transplant as the best chance of cure.
Yeah.
With Blincyto now, I think that's thrown a little bit up in the air in terms of whether a transplant is absolutely necessary. But for myself, I do think that particularly if that P53 comes with other chromosome changes, that is just of such a high risk that I would be nervous not to consider a transplant. for that individual. And for folks of mine that I've cared for with that same situation, more recently, they've all been going to transplants after treatment with me.
Okay, thank you.
Mhm.
All right, if we have any other questions, you're welcome to share them either verbally, like we just had, and we can get those answered right now, or you can send them in the chat and then I can read them. Um, so we'll go ahead and officially start our Q&A with that great first question. And then we can go through everybody else's questions if you have any about today's presentation or anything related to ALL. Something that I wanted to ask, this was a lot of information and it was presented really well. I think it helped make sense of a really complicated situation, complicated topic. If someone is wanting to start a conversation with their doctor about treatment options or treatment goals, but is feeling a little bit unsure on how to do that, what are some questions that you could suggest someone could use to start that conversation with their doctor? Or, if they're feeling a little nervous about bringing up a new therapy option or something they heard about today, how would you suggest that they could start that conversation?
Yeah, I say, don't overthink it. Just ask. I think a lot of us are very understanding that a lot of these terms are complicated, more complicated than it needs to be. Very long, very hard to pronounce, very hard to spell, so very hard to ask sort of as intelligently as you would wish to come across necessarily. So I would say don't feel worry about that. Even if you use immunotherapy, that term inaccurate, quote unquote, inaccurately or imprecisely, I think we would all be absolutely understanding of that. Um, I would just say, Doc, I've come across a lot of what they seem to call immunotherapies in cancer in general. Do you think any of it might be relevant for the treatment of my type of leukemia? I think that invites discussion. You can also ask more specifically, do you think blinatumomab has a role for me? So on and so forth. But absolutely, at least with me, don't hesitate. No need to think twice. We're here to meet you where you're at.
Something else, you are involved in research with your role and your practice. What are some of the things that are upcoming in ALL that you're excited about that you could share with us?
Yeah, sure. So, yeah, thanks, Mary. There's a lot of excitement about immunotherapies, particularly in ALL, because it works. And I wish I could say that for AML, the other type of leukemia, where we so desperately wish for immunotherapies as well, but have had a lot of challenges. Nevertheless, because it works so well for ALL, there's a lot of momentum to try and, as you may have heard me say, give these therapies to more people, right? Make them safer so that more people can use it, or make them earlier so more people can use it. One theme is, blinatumomab keeps inching upwards. It was approved primarily in the relapse refractory setting, as I was showing with this slide here. Blinatumomab is approved there until more recently gaining approval in the frontline setting, right? Moving into folks right at the beginning of treatment. And then with some even trying to move the blinatumomab way in the beginning after just a few rounds of chemo. I'm excited by similar motivations with CAR T therapies. CAR T therapies, again, if you look at this, has primarily been in the relapse setting, but why not try to bring it more to the beginning of treatment, right? Could it be that we do rounds of chemo, blinatumomab, CAR T therapy, rather than wait for leukemia to come back before giving CAR T therapy, right? So, of course, the trade-off is always safety. But I just mentioned that there is one such new um, therapy that is considered safer as a CAR T alternative, right? Obe-cel. So again, I think a lot of these developments are coalescing at the right time to hopefully bring these therapies to more people.
I think it's exciting to see the increase in not just approvals, but research in general in the leukemia space and here in ALL. it can feel like a lot as a patient if you're trying to stay on top of things and there's all these new names and new types of therapies to try to learn about. But it's such an incredible time in this research space with new options, new classes of drugs and things like that. So at HealthTree, we'll stay on top of it and try to keep everybody up to date with new options and bring on other incredible physicians to help us make sense of all of this. But it's really exciting to see the
Yes.
increase in research happening.
Yeah, and I think I would dovetail there and just say that don't you're welcome to absolutely educate yourself, look things up, but be kind to yourself and don't hold
Mhm.
yourself to the expectation of needing to learn this as if it's a college course. If only because so much is just of a different time before
Mhm.
blinatumomab in the frontline setting, before obe-cel, right? And even amongst our own docs, we are reevaluating everything. So we come into any new individual we care for with an open mind, right? P53 used to require a transplant. Well, do we now for this individual with how well they've done, with the level of support that they have, is that still the right decision for this individual in particular? So please trust your physician to do that. Certainly, we try to do our best um, to achieve that.
We have two questions. We have one from Susan and then a verbal question from Lisa after. So Susan's question is, are the bridging therapies until CAR T is done generally the immunologic therapies or chemo?
Yeah, good question. So it's really dealer's choice, and it depends in large part as to what category of treatment you've received before. Because remember, we don't need the bridging therapy to cure, but we do need it to work. So if your leukemia has survived prior chemotherapy, then we're unlikely to give you more chemotherapy. If your leukemia survived blinatumomab before, we're unlikely to give you blinatumomab again. What that really means when it boils down to it is that a lot of people, at least in my center, they receive inotuzumab as bridging chemotherapy or bridging therapy. So, and that is a form of immunotherapy if you sort of wish to consider it like that.
Thank you. And then Lisa, if you wanted to unmute, you can ask your question.
Can you hear me?
Yes.
Okay. Thank you for doing this. This is very informative. I have a 27-year-old son who was diagnosed with B-cell ALL in the beginning of September. He's been 1 week inpatient on Desanimab and prednisone, and then outpatient since then with anticipated December 1 starting blim,
Blinatumomab, yeah,
yes,
but Blina, yeah, we call it
yes.
Blina for
I
short.
just call it Blimpy because I can't ever
Blimpy's
remember
fine.
how to pronounce it.
I like that.
So once in December when he starts on Blimpy, is that going to be inpatient? And I'm sorry, and he's pH positive.
Yeah, so it's a good question. Uh, So yes, the treatment all sounds um, very expected in the way you described. Uh, he got the dasatinib steroids followed by blinatumomab. For blinatumomab, the very first cycle at most centers, he will be in the hospital, inpatient, but generally
Okay,
only. Mhm.
I'm sorry, he's working with Dr. Mustafa Ali at Cleveland Clinic.
Mhm. I don't know Dr. Ali personally, but yes, that plan sounds reasonable. He'll likely be in the just to go back to your question of expecting if he should be in the hospital, he likely will, but only for at least at our center, only for a few days to make sure that there's no CRS or ICANS toxicity in excess. And his subsequent rounds of Blimpy should be able to be given outside the hospital.
Okay, just with the pump, wearing the
Yeah,
pump.
that's right. Just the pump and getting the pump changed. Yeah.
Okay, so he
Sounds,
should just expect the first few days to be inpatient and then the
yeah.
rest possibly outpatient.
Some
And I'm
centers,
not
mhm.
completely up on all of this. he's been having weekly lumbar punctures,
Yeah.
and I'm probably saying this wrong, but his cancer cell blood gases in the beginning were 90%. 2 weeks ago, it was 0.1%,
The
and last
blasts.
week it
Yeah.
was 0.001.
Yeah, that's fabulous. I think that's suggesting treatment response. Um, I can't say specifically what that number might refer to because there's different ways we track the leukemia, but it does sound like the leukemia as a whole has come down, which is great. The other point I was going to make is that sometimes at certain centers, the second cycle of Blimpie is still in the hospital. Some centers still do that out of an abundance of caution.
Okay. And what determines if there's one cycle or up to 4 cycles?
Oh, that's a very important question in the field. We don't have the answer for the optimal number at this time. A lot of times it depends on what comes next. If after blinatumomab there's plans for a bone marrow transplant, then the number of cycles needed might just be whatever amount needed to cover your son until that transplant is ready, and enough to make sure that that number you mentioned at 0.01, et cetera, goes even lower, as low as possible.
Okay. And then in terms of a transplant, from what I've read, which is limited, um, the mother is a more likely candidate than the father.
That I
Is
probably can't speak to too much. Um, Both I think would be worth being considered as a potential donor, but there's likely a lot of different other factors at play here in addition to just gender, I think. Um, yeah, I'm sorry to say
Well, I had read somewhere that the mother carries, due to birthing the child, the mother carries part of the child's DNA in her body. And so that makes it less likely for the child to reject the mother's marrow.
yeah, I see where you're coming from. Although the father would be the same as well, having shared half of his genetics for
Well, what I had read was that, both the mother and the father share their genetics, but then the fetus shares its own genetics back to the mother. So the mother
oh, by
is
virtue of being having been carried by the mother. I see. I see.
right.
It's possible. I suspect transplant specialists might be able to speak to this in greater detail. At my center, unfortunately, my expertise goes up to the point of transplant, and at which point folks undergo the care of my transplant colleagues, I'm sorry to say.
Okay. And we've got a strange situation, and the father's had non-Hodgkin's lymphoma and has had chemotherapy,
Yeah,
so I've
I
been
see.
told he's not a candidate.
Yeah, other reasons.
Right. And my son is 27. I am 67. I had him late in life. Does that rule me out being of my age?
I wouldn't say so in a definitive manner. It's probably a factor that your physician is considering. Um, So I would leave it to them to kind of assimilate all of these various variables in their choice of a ideal donor.
And is there anything I can do in the meantime to increase the odds of success should I have to be a donor?
Not much more than what I suspect you're doing now, staying healthy, everything you're doing. A lot of the determination of a good match is genetics, which is not necessarily within your control.
All right. Thank you very much for all your
Of course.
information.
Mhm.
Lisa, I took note, and I'm working on planning our 2026 curriculum and end of the year. So I'll see if we can get a transplant specialist to come on and talk to us about transplant for ALL so we can hopefully give
Mhm.
you some good information to help.
Okay, thank you.
And then we have a follow-up to that first verbal question, talking about being
Mhm.
nervous. Once the treatment finishes, there's no treatment for 4 to 5 weeks before transplant. And then she says the doctors are saying she won't have to do another round. Is this something they should be concerned about?
Yeah, I see where you're coming from. It's hard for me to comment, I think, precisely not knowing the details of the case. Sometimes the consideration here of taking a break might be for recovery. It might also be because the response, the leukemia has already responded excellently. It might also be that, four or so cycles have been given already, and there's not a lot of good evidence for more to be given. So hard for me to say. I suspect, again, your physician may have good reason to, and yeah, I encourage you to ask them directly if any of those possible reasons I mentioned might be theirs.
Thank you for that answer. And thank you, everyone, for sharing your questions and being willing to talk about your situation in order to help, I mean, get answers for yourself, but also for other people who probably have very similar questions. So I'm really excited to be able to have this opportunity and for you to join future webinars to have the opportunity to get all of your questions answered as you go throughout your experience with ALL as a patient or as a caregiver. So thank you everyone for sharing today, and thank you, Dr. Chen, for coming and presenting and answering everyone's questions. I think this was a really helpful webinar.
Great. Thanks so much, Mary. It was a pleasure.
Before we officially wrap up, I just wanted to take a moment to thank everybody for coming today. As you leave the webinar, we really would appreciate you taking the 2 to 3 minutes to fill out the brief survey that's going to pop up. It's a chance for you to tell us what you thought about today's event, but most importantly, for you to share what you want us to see in the future. Like I just mentioned with Lisa, I'm building our curriculum for ALL for next year throughout the rest of the month. So I would really love to include topics and questions that you guys have questions about so that we can make sure we bring on specialists centered around each of those topics to make sure we get your questions answered in the best way possible. So when that survey comes up, please share your ideas so that I can incorporate them into our plan for next year. Also, if you're interested in other types of support, HealthTree is hosting in-person events called Connect to Cures. The team will be in Grand Rapids, Las Vegas, and Spokane coming up soon. And I'm actually going to be at the Grand Rapids event. So if you live close by, please come. I would love to meet you. They're free community events for all blood cancer patients and caregivers where you'll get to hear from local specialists and a panel of patients from the area, and then HealthTree team members about how we can help solve some problems that you have and meet needs that you individually are experiencing. These are really amazing events. I've really enjoyed the ones I've been able to attend. So if you live close by to any of our final events for this year, I'd really encourage you to try to go. They're free events. They also include a meal, and you'll get to meet other patients in your area. We have 10 new cities that we'll be going to next year that we are really excited about, that you'll start seeing advertised here soon. One of them is in my hometown in Missouri. So excited about next year. We're going to have a lot of cool opportunities to engage with people in different areas. So please attend if that's something you're interested in. As always, we like to thank our sponsor, Amgen, for making webinars and education like this possible. And then in closing, I just want to say a big thank you for being part of our ALL community and for attending today's event. Your support means a lot, and we're really grateful to have you here. I've included my personal email on this slide, so please don't hesitate to reach out if you have any questions about HealthTree, anything we talked about today, any HealthTree programs, or if you're interested in sharing your experience. I set aside time every week to meet with members of our AOL community to get to know you, to hear your story, to help connect you to resources, hear your thoughts on topics, and just generally get to know the people who we're trying to help. So meeting with people is my favorite part of my job. So please send an email if you'd like to connect, and I would love to meet you. I really appreciate everyone, and I hope you have a wonderful rest of your day, and then hopefully we'll see you on another webinar soon.
Great. Thank you, Mary. Take care, everyone.
Bye.